is Riley Fortner. I'm a medical student at Texas Tech University Health Science Center. First, let me say thank you to everybody for being here and the SMA for putting this on and allowing us to share these interesting works. So today I'm going to share with you all a case report involving vocal fold paralysis following anterior blunt trauma to the neck. Vocal fold paralysis is not typically due to anterior blunt trauma. Most of the etiologies include neoplasm, sharp trauma to the neck, or things like iatrogenic damage during thyroidectomies. Depending on whether or not the paralysis is unilateral or bilateral, symptoms can range anywhere from hoarseness to difficulty breathing, in which case the airway would need to be secured. Just a little anatomy refresher for everybody that may not be as familiar with the recurrent laryngeal nerve. It is a branch of the vagus nerve. On the right, it wraps around the subclavian artery before ascending back into the neck, while on the left, it wraps around the ligamentum arteriosum before ascending into the neck. On both sides, it enters the tracheoesophageal groove, diving deep to the thyroid gland and parathyroid gland before entering into the inferior pharyngeal constrictor, and ultimately providing parasympathetic, sympathetic, and motor innervation to the larynx. So as you can see, because of its position in relation to the thyroid gland, it's very susceptible to injury during those types of surgeries. So just getting into the case here now, patient was a 31-year-old male in Lubbock. There's strong wind, so a strong wind knocked him off of his bicycle, where he struck the right side of his neck on the receiving hitch of a truck. In the ED, physical exam was notable for crepitus in the neck, and the CT scan revealed 2 areas of tracheal rupture inferior to the vocal folds, a right pneumothorax, and a pneumomediastinum. Getting into his management and the patient course in the hospital here, shortly after his arrival, the patient decompensated and was intubated secondary to stridor. In the OR, the defects in his cricothyroid membrane were repaired, and the patient remained intubated for 3 days with a planned direct laryngoscopy upon extubation. Once he was extubated, the patient developed inspiratory stridor that was unresponsive to both racemic epinephrine and decadrone. At this point, a flexible bedside scope revealed bilateral paramedian and paretic vocal cords. A tracheostomy was placed as to secure his airway during the recovery of his vocal folds. 3 days later, a repeat flexible scope revealed that the right fold was hypomobile while the left fold was moving fairly normally. 2 days later, the patient was discharged with a plan to decannulate at a later date in clinic. 2 days following his discharge there, he was readmitted for an unrelated issue, and the day following, a repeat scope revealed a right midline fold with a hypokinetic left fold. 2 days later, another bronchoscopy was performed, revealing both folds approximating midline with a slight posterior gap. There was complete adduction with acute phonation on breath hold, and additionally, there was complete abduction at rest. The tracheostomy was downsized at this point, and the patient was discharged the following day. Ultimately, 3 weeks after the initial tracheostomy was placed, a follow-up clinic at the ENT revealed that both vocal folds were moving completely normally, and at this point, the tracheostomy was removed without complication. Up top right there, you can see the image at that 3 weeks post-tracheostomy. As you can see, the vocal folds there are both completely abducted, and at this point, they were moving completely normally. So why does this case matter? As I mentioned before, vocal fold paralysis is caused extremely rarely by this anterior blunt force trauma. And so it's not a high index of suspicion often when this type of trauma presents. So there needs to be some suspicion there. Additionally, it must be managed closely during that recovery phase. Going back to his hospital course here, at certain points, the left fold was moving well, and then 2 days later, it was hypokinetic again. And so it must be monitored closely throughout that course because it may look like it's healing well and then kind of get worse a few days later. And then finally, the definitive management of that unprotected airway for this recovery is the tracheostomy. Again, I'd like to thank everybody for your time, for listening to this presentation, and I will open it up for questions with that.
All right, we do have one question, and that is, what would be the contraindication to leaving the endotracheal tube in place for longer than 3 days to spare the patient a tracheostomy?
From my understanding, it was the extent of the trachea damage I would need to refer to a surgery textbook, which I haven't looked at in quite a while, but I think with that, the damage to the trachea as it was indicated that they only be intubated for 3 days.